esophagus. So just a little bit of review of anatomy. Your esophagus is about 8 inches long. The upper third has some voluntary control. The lower 2/3 is pretty much involuntary. Can you guys see where the upper esophageal sphincter and lower esophageal sphincter is?
Yeah.
So the lower esophageal sphincter's job is mainly to prevent acid reflux, so it remains closed unless you're swallowing. And the upper esophageal sphincter's main job is to prevent aspiration. So it remains closed as well, and you have some voluntary control over it. Layers of the esophagus. So remember, all the way in the middle is mucosa, and then working your way outward, submucosa, muscularis. After the muscularis, in the chest, what's the last layer? So it's adventitia first until it gets past the diaphragm into the abdomen. Then it becomes serosa. So remember, adventitia is where an organ is kind of more stuck and doesn't move around, and serosa is when it gets down into the abdomen, so it's can move around a little bit more. Okay, Mel. What is the layperson term for deglutition? Do you want a hint?
Yes.
Yes. So before we go into all the different disorders of the esophagus, let's talk about dysphagia first. So basically means difficulty swallowing. So remember, if it's spelled with an S, it means difficulty speaking, and it's pronounced dysphagia. So there's a couple different main phases that are involved in whether or not you have difficulty swallowing. So the first phase is the oral phase. So what all is involved in that? So when you guys are eating something and you're going to swallow it, what are all the things that are involved that affect your mouth and pharynx? So your tongue obviously has a job to do, right? It helps form the bolus. What cranial nerve controls the motor function of the tongue? Yes, hypoglossal. So cranial nerve number 12. So that's all motor function of that nerve, and it helps the tongue move. Okay, somebody said facial nerve. What does facial nerve do with the tongue?
Sensory in the tongue.
So it controls taste for the anterior 2/3. Okay, so then your teeth are also involved, right? So your cranial, what's your facial nerve? Is cranial nerve what? 7. So you have to be able to clench your teeth and use all your facial muscles in order to chew your food. In addition to that, what are the muscles of mastication? What does mastication mean? Chewing. So what muscles are involved in that? Masseters, temporalis, what else? Pterygoids, yep. What cranial nerve innervates those? Yes, trigeminal, which is cranial nerve 5. Which branch? Yes, good guys. Mandibular branch, excellent. Okay, so far we've said, 3 at least different cranial nerves. Then you have the pharyngeal phase. So, bless you. Also involved in the oral phase, right, you have to have adequate saliva. So facial nerve also controls secretions of the submandibular and sublingual glands that secrete saliva. And then glossopharyngeal controls secretions from the parotid. So if you have dry mouth, that makes it difficult to swallow too. Okay, then the pharyngeal phase involves your soft palate has to elevate, epiglottis has to close, and your upper esophageal sphincter has to open and close. So what are the cranial nerves that are involved with the posterior pharynx, your gag reflex, elevation of your posterior pharynx and uvula and all that. And? Yes, so 9 and 10, what's 9? Glossopharyngeal. So glossopharyngeal is mostly sensory in that area, and vagus does most of the motor function in that area. So I think so far we've said at least 5 different cranial nerves. And then there's your esophagus. So that's all before you even get to your esophagus. The esophageal phase is mostly about peristalsis, so can it move the food down, and can the lower esophageal sphincter open and close when it's supposed to, and that's mostly under control of the brain. So upper motor neuron nerves. So swallowing is very complex, and where there's a disruption in it, it's important to determine, is it oral pharyngeal disruption or is it esophageal disruption? Okay, Mo, pronounce this word.
Dysphagia.
Yes, pronounce this word.
Dysphagia.
Excellent. Everybody knows that? Okay. Okay. Group effort.
Dysphagia. Ready? 1, 2, 3. Oh, we're supposed to be saying.
No, it's a different question, but you can do but you can do that. You can do that too. Do it, Steph. Take it away.
Dysphagia. Dysphagia.
Good. Okay, so this one, how many cranial nerves are involved in swallowing? More. 5 is what I have down, but actually there's 6, really. We didn't talk about the cranial nerve 11, the accessory nerve, which innervates your SCM. So even like turning your neck is a little bit part of swallowing. Okay, so which ones? So we said trigeminal, right? So you can, yep.
Vagus. Glossopharyngeal. Accessory.
Good. So trigeminal, so you can chew, facial muscles, parasympathetic to sublingual and submandibular glands. 9 and 10 are involved in posterior pharyngeal movement. And then remember, hypoglossal is all motor function of the tongue. And then even really accessory nerve for movement of the neck. Good. So don't forget your epiglottis needs to shut. In order to prevent aspiration. And anything disrupting this area from the upper esophageal sphincter up is considered the oral pharyngeal dysphagia, and then from there down is considered esophageal dysphagia. Okay. So why does it become more common in people who are hospitalized or even in long-term care or skilled nursing facilities? Okay, so deconditioning. So somebody's hospitalized or in long-term care is maybe becoming malnourished, their activity is lessening, their illness is affecting all of those things. Also, a lot of times, why might somebody be in a long-term care facility or skilled nursing facility? So maybe they've had some kind of stroke, either hemorrhagic or ischemic. So something affecting upper motor neurons, which then ultimately is going to affect their cranial nerves, or they have an issue with their cranial nerves. Yes, Steph?
What about, I remember I took a class and it was about aging, and they said that when you don't like engage your brain, right? Like you're not like really social, you start losing that like function, that motor function.
For sure, 100%. So exercising your brain is just as important as exercising your body. Absolutely. So that's, you can almost kind of think of that as somebody getting deconditioned. So, you know, you get sick, you go into the hospital, you go into rehab, and if you're not really rehabbing and you're just laying in the bed and you're not activating physically or mentally, then yes, you slowly start to lose those functions. That's completely correct. Also, could these patients potentially be on medications that cause dry mouth, or maybe pain medications that reduce their, you know, cognitive function to tell them how to swallow? So all those things are increased when you're hospitalized. Okay, so remember, 3 main types: oropharyngeal, esophageal, and then what is functional dysphagia? What does that mean? Right, so there's nothing comes up abnormal on imaging, on biopsy. You know, the person is telling you, I have difficulty swallowing, but when you look, there is really nothing to explain why that's the case. And remember, that's a diagnosis of exclusion. Okay, another group effort. Okay. Your patient presents with drooling, dysarthria. What's that?
Can you make the words?
So you can't like articulate the words. Good. A sense of food getting stuck immediately upon swallowing, post-nasal regurgitation, coughing, choking when they eat. Which of the following do you think is the cause? Oropharyngeal, good. So remember, oropharyngeal, that's your patient who's likely to just not be able to initiate the swallow. You know, they can't control their oral secretions. Food is going to feel like it's, you know, kind of regurgitating maybe back up into their nose. They're at high risk of aspiration. Whereas esophageal dysphagia is more, they can initiate the swallow, but then a few seconds later they feel like it got stuck. So oropharyngeal dysphagia, a lot of times your patient may say, it feels like it's getting stuck here. Where with esophageal dysphagia, they're gonna point usually more to their like substernal notch. It feels lower. So all of these questions are things you're gonna ask your patient to elicit the pertinent history to try to figure out, okay, which of those types of dysphagia is it? It's really important to know when you're trying to figure out what the cause is, how did it start? Was it that they at first were saying, you know what, I just couldn't swallow huge chunks of food for a month, and then it was all solid food, and now I can't even sip water, versus I woke up and I just couldn't swallow anything. That's really important to distinguish between those two things so you can figure out which, you know, of the diagnoses we're going to get to that it is. Why do we care if they have a history of smoking or alcohol use?
Carcinoma.
Exactly. So increased risk of potentially oral or esophageal cancer. Why would somebody who has dysphagia also maybe have a fever or ear pain? Say it again. Yeah, so they could potentially have an infection. Also, remember what drains into your posterior pharynx, or how does, through where? So your eustachian tube. So if you're having a difficult time swallowing and you're pooling secretions, you can also, they can, you know, kind of back up into your eustachian tube and cause ear pain or infection. Vocal changes, either because of aspiration or malignancy, is important to know too. So would you say that if your patient came to you and had difficulty swallowing, that it would be alarming?
Could be.
Absolutely. Always. Dysphagia, always, 100% of the time, every time, is an alarm symptom. And you have to look and see why. So when it's acute, and almost always every other time, unless you have a very good explanation, you're going to go in and look with the camera. So you're going to do an endoscopy. And you're going to see what the heck's going on. Why can't my patient swallow? And then I'll talk about some other tests you can do.
Is that like the first option for
Acute presentation, always. Go in and look and see. Yeah, right away. And then this is not for you guys to memorize, but just, again, why it's important to know what their symptoms are and what the onset was. Is it intermittent? Are they telling you, once every 2 weeks, all of a sudden I can't swallow, then it goes away and I'm fine? All these clues lead you to try and figure out, is it something that's slowly getting worse and is progressive, or is it something that's, intermittent, and that helps you narrow your differential one way or the other. Okay, so let's talk about esophageal dysphagia specifically. So don't get too fixated on whether it's a motility problem or mechanical problem, because either one can cause the other. But when you hear that term, motility problem generally is meaning that there's an issue with peristalsis of the esophagus. So something's wrong with the movement. Versus mechanical means there's an actual obstruction and the food or liquid can't get down. So things that usually cause motility problems, spasms of the esophagus, when we're going to talk about all those disorders today. Scleroderma is hardening or fibrosis of the esophagus. We'll talk about achalasia today too. Mechanical, so for some reason it's become narrowed or there's a mass, so there's an obstruction. And we'll talk about mucosal rings today too. You can also have infections of the esophagus. So infections can cause both of those issues. So if your esophagus becomes inflamed enough, it can affect motility and peristalsis. And then the inflammation can become so advanced that it actually creates an obstruction. Okay, so what are some things that can cause inflammation and narrowing and ultimately obstruction of your esophagus? Excessive exposure of the esophagus to acid, any kind of trauma. So if you're placing NG tube, especially repeatedly in a big one, you can cause damage, inflammation, and irritation of the esophagus. Pill irritations. Anybody ever just swallowed a pill and it's stuck in your throat and you feel like you're dying? So certain pills, especially iron that are very caustic, can cause inflammation and irritation to the esophagus. And typically those are something that's progressive and mechanical. So it gets worse and worse slowly over time, and it ends up leading to obstruction. So that's what progressive and mechanical means. Esophageal cancer, another one that's progressive and mechanical. So we'll talk more about this when we talk about reflux next week. But this is one where all of these really, but they're classic, where your patient will tell you, I first couldn't swallow big foods, then any food, and then ultimately I couldn't even swallow liquid. That tells you something's slowly, progressively getting worse. And then these little guys, sometimes the mucosa of the esophagus just kind of pouches in. So if normally your esophagus is like this, sometimes the mucosa will just make what's called a web. And the mucosa and submucosa will just pouch inward. So you can see where then food trying to get down can get stuck. When this also includes the muscularis layer, it's referred to as a ring instead of a web. Except for Schottky ring, because the guy that named that decided to name it a Schottky ring, even though it doesn't contain the muscularis layer. So Schottky ring is technically a web. Not that that really matters for anything, but when the muscularis layer is also pouched in like this, they actually are better because they can contract and relax, where when it's just the mucosa and submucosa, they're more likely to just get stuck, and they have to go in and kind of use a balloon to squish it. And of course, this isn't. I forgot my thing again. Steph might need to borrow yours. Okay, Bradley. These rings are usually mucosal and located near the gastroesophageal junction. Would you like a hint? Schottky rings, very good. Schottky, thanks, Steph. Okay. So scleroderma, have you guys learned about this in room yet? So you get this likely more in derm, but it is thought to be due to autoimmune dysfunction, and basically it causes hardening and fibrosing of areas of the GI tract and skin. So you can imagine if your mucosa of your esophagus is now leathery, would you imagine that that would cause an issue with motility and difficulty swallowing? Yes. Spastic motility disorders usually involve some type of intermittent spasm of the esophagus. So DES is diffuse esophageal spasm. Nutcracker esophagus is, again, another kind of spasming of the esophagus. And then non-specific esophageal motility disorder also is under that category. So they all get diagnosed because they have slight variations in the amplitude and how coordinated or uncoordinated the spasm is, but they're all under the same category. Yes?
Sorry, what was the DES again?
Diffuse esophageal spasm. And then achalasia, so literally no movement. We'll talk about a little bit more later in the lecture, is basically a neurodysregulation of the esophagus. So there's not enough inhibitory neurons or neurotransmitters in the LES, so the LES remains contracted all the time. And then there's not enough excitatory neurotransmitters or neurons in the rest of the esophagus, so the rest of the esophagus just isn't peristalsing when it should. So you end up at the bottom of the esophagus is just contracted, and the rest of it is just kind of bloated because more and more food's trying to get down and it's getting stuck and accumulating. And then we'll talk about Zenker's diverticulum today, and really think of anything in your chest. So if somebody has an aortic dissection, the aorta is like right close to the esophagus. So if it gets enlarged enough, it can compress the esophagus. Any type of tumor in the chest, all those things can cause esophageal dysphagia. Okay, oropharyngeal dysphagia. So again, remember, these guys are going to be coming to you complaining that they have a difficult time controlling food in their mouth, making a bolus. They'll be drooling, regurgitating. It's the initiation of the swallow that they have difficulty with. So it's that immediate trying to swallow that they can't do. And this is just a short list of all the things that can cause that. So remember, anything upper motor neuron, so stroke, Parkinson's, any kind of neurodegenerative disease, demyelinating disease, so myasthenia gravis and MS. Bell's palsy affects what cranial nerve? 7. So anything that affects any of the cranial nerves that we talked about, remember the 6 of them, can affect oropharyngeal dysphagia. Dry mouth, Sjogren's disease is an autoimmune disorder that affects any organ that causes lubricating of the body. So for example, tears, dry mouth. Any disruption of oral mucosa. So if somebody has a lot of sores in their mouth, if they have poor dentition, radiation therapy to the neck and face. All of those lovely antiemetics that we talked about can cause dry mouth and cause this. So always when your patient comes in, start making a list for yourself of, okay, which side of these do you think the cause of their dysphagia is, and that'll help you figure out what test you want to do to figure out what it is that they have. Okay, so where do you start? Obviously, detailed history, distinguish between oral or esophageal cause, excellent cranial nerve neuro exam, head to toe exam, obviously, but definitely focused in those areas. It's hard to, what's dysphonia?
Make sound. Can make a sound.
So it's like a change in the way you speak. So a change in your voice quality. So it's hard to know that if you don't know your patient, right? You don't know. Maybe they always sounded a little hoarse. You see that little horse? So it's important to, ask whoever it is that knows them. But notice that about your patient. If it's a repeat patient, you're like, whoa, what's wrong with your voice? And they're like, oh yeah, I've been noticing for 3 months it's been getting like this. That's concerning. Tongue mobility and strength. Okay, so we're going to teach you guys when we do the exam, neuro exam and physical diagnosis, how you assess tongue mobility. So you want to make sure that when they move their tongue, it's symmetric. It's not deviated to one side. It doesn't have a tremor. That their tongue movements are strong and not weak. And then checking to make sure that their soft palate and posterior pharynx rises symmetrically. And then why do we care about a thyroid exam?
Oh, because of goiter.
Right, exactly. So if your thyroid is enlarged, can that potentially cause issues with swallowing? Of course, yep. Okay, JP. How do you think you assess tongue strength in your patient? Do you think that you ask them to repeat this? Or this? Or this?
The second one?
Correct. So actually what you do, and you can do it to yourselves, if you put your hands, you put your hand on your patient's cheek, and you tell them to kind of poke their tongue against your hand. And it should feel the same both sides. If one side feels significantly stronger and the other side you can feel the tongue tremoring or not even able to perform that movement, then that's when you guys know, uh-oh, there's some issue. So let's try and figure out what that is. Okay, so complications, obviously aspiration. Why dehydration? Because they're not able to take in nutrition, so malnutrition as well. Incidentally, what is the first muscle in your body to atrophy when you're when you're malnourished? Anybody have a guess? What is the first muscle to atrophy due to malnutrition?
Tongue?
One of. No. No, but that gets wasted after a while. Your diaphragm. Your diaphragm. So that's why a lot of times patients will also, who have difficulty breathing, who can't get weaned from a vent, and they're extremely malnourished, is also due to deterioration of their diaphragm. Why renal failure? What does that have to do with anything?
It's gonna decrease your volume.
What? Why? What? Why? Right. So you're dehydrated. So your blood volume's decreased. So it can cause you to go into renal failure for sure, especially if you have other comorbidities. Renal failure due to volume depletion is referred to as pre-renal acute kidney injury. Pre-renal acute kidney injury, or AKI. Okay, so if you do aspirate, what is the most common lobe to aspirate in?
You're right.
Right what?
Right lobe. Upper.
Close. You're on the right track. So right middle lobe, because most people do aspirate also while they're sitting. So if you're seated and you aspirate, it's most likely go into your right middle lobe. Why does it go there?
Just straight.
Exactly. So your right mainstem bronchus, right, has a more vertical and also larger diameter. And gravity is going to help that. Okay, what if you're standing and you aspirate? So it's a little bit more gravity to help it. So typically, if somebody's aspirated into their lower lobes, you can just wonder if they were standing when they aspirated. And what if I, was under the influence of a substance and passed out and landed on my back and aspirated? Where would it likely go? So right upper. Yep. Good. Okay. So you do your typical lab studies. So what's the bare basic lab study you're going to start off with for everyone? CBC with differential, then your chemistry panel. Then you got to decide, well, what kind of imaging do I want to do? And that depends. Again, if somebody presents acutely, you go straight to endoscopy. You want to look and see. If you've already determined that potentially it's oropharyngeal dysphagia, then you can do what's called a FEES. So it's called either flexible or fiber optic endoscopic evaluation of swallowing. I'll show you a quick little video. Or modified barium swallow test. So the difference between these is, for the first one, for the FEES, you literally have a camera that you place through someone's nose, and it goes down to about the level of the vocal cords, and you can just physically actually see when they're swallowing if they're aspirating. It's just that once the epiglottis closes, you don't see on the other side of it. With video fluoroscopy or modified barium swallow, you give your patient barium somehow mixed in with scrambled eggs or a specific type of thickened beverage, and then you're taking X-rays, live X-rays while they're swallowing the barium, and so you can see the barium. So it's really good for visualizing like the moment that they swallow and the esophagus. Let's see if I can get this to come up.
I'd like to take a couple minutes to kind of describe for you what's
I know you can't
easiest
see
and how
it,
it's been
I'm
around
fixing it.
and how it can help your patients and your
Half the time it works just fine, and then the rest of the time it doesn't. Okay, here we go. Can you guys see him now? Yeah. Okay.
And describe for you what's FEES and how long it's been around and how it can help your patients in your facility. FEES is basically an acronym that stands for Fiber Optic Endoscopic Evaluation of Swallow Study. The term was originally coined in the mid-1980s by Susan Langmore, PhD, when she started doing research on this procedure. The procedure basically consists of passing a fiber optic scope, much like this one, transnasally on the floor of the nose.
So can you guys see, like this is what you would see. So that's the epiglottis, but you're limited, like you can see the vocal cord folds here, but once the epiglottis closes, you can't really see what happens past. But the person who's usually is a speech therapist that's trained to do this, but whoever is trained to do this, if they're doing it very well and very correctly, it shows, has a very high sensitivity and specificity for detecting aspiration. Has anybody ever seen one of these? Okay, so there's that option. Then there is also so can you guys see the difference? So this is where you're giving your patient barium and they swallow it and you're just taking real-time x-rays. So can you see the epiglottis when it shuts? Do you guys all see that? So this is like a little bit easier to visualize, but here's the problem. This one exposes your patient to radiation. And depending, like, you need to also kind of push the patient to the point of fatigue. And you may not be able to expose them to radiation for as long as it takes for you to figure out if they're aspirating or not. They also have to be able to, be taken to the radiology suite, usually. Where with the other one, the fees, you can actually go right to the bedside and do it. And it doesn't expose them to any radiation. So it's a little bit more, flexibility that way. But it depends, exactly what it is that you're trying to, to look for. If it's something in the esophagus, it's really not going to help you to do the fees, right? Because you can't even get down into the esophagus. So you either need to do an endoscopy, or if you're just trying to visualize whether the epiglottis is closing properly, and you want to see lower down a little bit, then you need to do the modified barium swallow. Okay. Other things that you can do once you've ruled out that it's anything alarming. So now you're thinking, okay, it's not a malignancy, it's not a cranial nerve, it's not an upper motor neuron issue. I think it's reflux, causing maybe some stricturing and narrowing of the esophagus. So you can do pH monitoring, which we'll talk more about next week, to see if it's for sure reflux. Or you can do esophageal manometry to assess for peristalsis issues or spasm issues. Where in that case, they actually insert a pressure probe all the way down to this bottom of the esophagus and then slowly remove it, and it measures how much pressure is within the esophagus and if it's an appropriate amount or not. But those are secondary to ruling out anything that's alarming. So here's what this looks like. Has anybody seen one of these done? Modified barium swallow? Yeah. A few of you guys. And then here's the fees. So you see that fiber optic scope is inserted transnasally. Do you think you sedate your patient for either of these procedures?
No.
Why?
Because you want to see how.
Right, are you swallowing appropriately when you're sedated? No. And there's just anatomy of the epiglottis and larynx. And then this is what it would look like on the fees. So your esophagus is back here, and then your vocal folds are here. And this is your epiglottis, right? So it closes over your larynx so that food can go back here. So this is just kind of a pro and cons list for both. If you have major facial trauma, you really can't use the fees. And I gave you guys this chart, right? Okay. So which one, if you think the patient has esophageal dysphagia, which one's better to order out of these two? The barium swallow, right? Or an endoscope, right? Where you go and you kind of look all the way down towards into the stomach. Okay.
Hey, when I get these keys on, boy, don't move my car, man. All right, in front. Don't move my shit, man. Oh, baby, what's your name?
Where's Camp? Oh, there she is. Yes. And yes. So cranial nerve 9 and 10, right? So remember sensory function and then motor function. So sensory function to the posterior pharynx, epiglottis, upper esophageal sphincter, and then motor function with vagus to actually make movement. Okay. Nutrition, extremely important in your patient who can't swallow. So, vital that you get your speech therapist and speech pathologist and dietitian involved. Speech pathologist is going to determine what kind of consistency of food the patient can have and not aspirate. So they may tell you that if it's oral pharyngeal, potentially they will never be able to drink something that's thin or water consistency again. It's actually much more difficult to control something thin in your mouth than something that's thicker. So that means also ice cream or a popsicle, which starts off thick but then becomes thin in your mouth, counts as a thin liquid. So your patients may not be able to have that. And then the dietitian is going to make sure that all of their nutritional needs are being met appropriately. Sometimes these patients will need some type of feeding tube. So a PEG is a percutaneous endoscopic gastrostomy tube. So that means you go in through it with an endoscope all the way down to their stomach, and then you shine a little light, and from the outside you see the light, you make a little incision, and then you just put a little tube in there. And that's where you feed them through. Nasogastric tube goes through the nose, goes the same place, but there's no surgery. So that's for a little bit more short term. And then PEJ is percutaneous endoscopic jejunostomy tube. So same as the first one, except it goes all the way down to the jejunum, or potentially even to. If you are worried that your patient's going to aspirate and you want to feed them with a feeding tube, where should the tube go past so they have the lowest risk of aspiration? You're never going to feed them anywhere closer than the stomach. So it has to go into the stomach at least. You can still aspirate from your stomach though, right? So if somebody has a high risk of aspiration because they can't control this area, and you're feeding them in their stomach and it's just pooling and pooling and pooling, they're still going to maybe aspirate those contents. Where would it be best to feed them? Past what? Yes. So if you get past the ligament of Treitz, you significantly reduce their risk of aspiration. Now, you still make stomach secretions and you can still aspirate your saliva. So it's not like 100% that they're not going to aspirate, but it's very helpful. These patients are at high risk for dehydration. So if you can't have anything that's water consistency, it's difficult if you're not getting an IV to maintain your hydration. If you have a feeding tube, you can put water in there because that's past all of this, that's fine. Why is oral hygiene important? I mean, in everybody, it's important, but especially with these patients.
There's no saliva.
Because why?
You don't want to decay.
Why does that matter?
Well, also you can't have like dental work, right? Because you can't.
Not necessarily. What is it? Okay, what about it? I mean,
There's more in the hospital, right? So you would want to like brush your teeth more often so that you reduce their chances of like an infection.
infection where?
Yeah.
So remember, these guys are at high risk for aspiration. So the worse oral hygiene you have, the more likely you have oral pathogens, and the more likely that when you do aspirate, you'll end up with a respiratory infection. So very, very important oral hygiene. And it's more difficult for them to maintain it, right? They're more likely to have a dry mouth. They're more likely to maybe just not even notice the oral hygiene. So then there's I think I showed you guys this before. So somebody who's just now can only maybe be on a puree diet, it's very limiting. So making sure they're getting all of their macro and micronutrients is very important. There's all these different things that you put the food in so it comes out looking like peas, but it's really just pureed peas. See it? Not super appetizing.
They need to try it so we know what our patients will do.
Yeah. I mean, if you can, but that's why it's also important too that they, practice making it flavorful, adding, enough herbs and spices so that it doesn't just taste terrible, because that's going to contribute to their malnutrition.
No, it's really made me gag.
There used to not be pre-thickened water, juice, and milk, and now there is, which is nice. You used to have to just thicken it yourself, yeah, and then it's just like a disaster. It's clumpy and gross, and you're assuming the person that's mixing it is making it the correct consistency. Now it all comes pre-thickened, so it's better. It's much, much better. But still, it's not really thirst quenching to drink honey thick water. It has it definitely has the taste. So they use a maltodextrin, basically a fibery carbohydrate to thicken it. So it does have a little bit of a weird flavor. The juices are better because it has the juice flavor to it. So what's the treatment? It depends what the problem is. So if it's an upper motor neuron or a cranial nerve issue, the speech pathologist can also work with your patient to teach them a lot of different oropharyngeal maneuvers. So they can do tongue strengthening exercises, they can do vocal cord adduction exercises, they can teach them when to cough, how to tuck their chin, when to turn their neck. So all these things so that they can, become empowered to help themselves not aspirate and strengthen their oropharyngeal muscles. There's actually transcutaneous electrical stimulation of some of the muscles of the neck that can be done. Obviously, if it's something that needs to be removed, if it's a malignancy, a mass, a web like we talked about, a Zenker's diverticulum, which I'll show you later, then surgery might be the answer. So it depends what the cause is for the treatment. Okay. Allie. Uh, 2012. Do you remember? It was the London Olympics, and they had the Queen jumping out of the helicopter. It was hilarious. It was really, I have to say, super creative. Okay. Nausea with a twist. So let's see if we can solve this case. So you have an 81-year-old female presents with a 2-day history of nausea, retching, but they can't vomit. So they're kind of dry heaving, but they can't actually vomit. For the past 3 weeks, she's been experiencing dysphagia and has only been able to swallow small amounts of liquids, along with she is able to belch, and she's had weight loss. She denies any abdominal pain, has had normal bowel movements, and she denies any changes in her speech or vocal changes. So you get her past medical history and you find out that she was diagnosed with a hiatal hernia in 2016 and she was diagnosed with esophagitis, so inflammation of her esophagus, in 2018. She's on omeprazole, which is what? Okay, which stands for?
Proton pump inhibitor.
Okay, good. And she's almost done with it. You look at her vital signs. What about her vital signs seems weird? Okay, so her heart rate's high and her blood pressure is low. And just knowing what you know in that history, what is it? Yes, heart rate is high, BP is low. What do you think is the reason, just based on what you know? Yes, so she is just dehydrated. So, because why? Because she told you for 3 weeks she's not really able to swallow anything. So you do a physical exam, and pretty much it's unremarkable, other than she has some like hyperactive bowel sounds. All her cranial nerves are fine. Your neuro exam is totally fine. Okay. Well, let's see. Do again. First, before you guys come up with the differential, what other questions do you want to ask her about her history? Excellent. So is this something that's been slowly getting worse and worse? Or is it something that comes and goes? So she tells you, no, it doesn't come and go. It's kind of slowly been getting worse, and now it's like the worst that it's been over the course of the last 3 to 4 weeks. More questions. Anybody can ask.
Is it just solids or liquids or both?
So initially it was kind of more just solids. Now even liquids are getting difficult to swallow.
Hard to swallow right away.
Good. No, it's not hard to swallow right away. It's after like a few seconds that it feels like it's just like getting stuck someplace. Kind of like down over here.
Someone asked already, like, is it like solids or is it liquid?
It started with solids and now it's kind of progressed to liquids.
Had any heartburn?
Yes, really bad heartburn. Yes. No. No smoking, no drinking. You guys have an idea for the differential? Anyone? This is a hard one.
Is it that angle?
Say again.
The angle of his is affected?
Okay, fancy, but what would be your differential? What's a disease that you think she might have?
Achalasia?
What is it?
Achalasia?
Okay, so she could have achalasia. We'll talk more about that later. What else? What area of her anatomy do you think is affected?
Lower esophagus.
So lower esophagus, maybe even lower than that. Okay, so what she's describing, maybe she has an obstruction, maybe she has a motility disorder. We don't know. Maybe she has peptic ulcer disease. What did we know about her history? So she had a hiatal hernia, and then she just like had inflammation of her esophagus. Why? She didn't tell us, and we don't know why she had this random inflammation of her esophagus. It was never really diagnosed for a reason. It was just found, and she was treated with acid reduction medication. Okay, so what test do you guys want to do on her? Do you want to do a fees? No. Okay, so you could do a barium swallow. Excellent. What else maybe? What was it? Okay, you could do an endoscopy. Excellent. So you do those two things and you see what it is, and then you decide, you know what, I also want to do a chest CT to better visualize the chest anatomy. And your chest CT comes back looking like this. So are you guys oriented with how this is like on the body? Does anybody want me to show you? Right, so if I was laying like this and you were just taking slices, that's the orientation of it. Okay, so what is the white thing?
That's the back, is the vertebrae?
Let's see. What's this white thing?
Heart,
Okay, that's correct. That's the heart. And this is
the vertebrae.
the vertebrae. And then what the heck is this that's like right really close to the heart?
Doesn't it look like it's like two esophaguses, but it's because the hiatal hernia?
So that's really good, Stan. I mean, is there supposed to be something else right here by the heart? No. Okay, so you're like, I don't know what that is. Your report comes back and says there's like this air-contained organ that has like a septum in the middle that's behind the heart. And then you look at a coronal view. So can you tell now what it might be?
No.
So, okay, so there's the liver, right? So your diaphragm's here. Your diaphragm's here. What is this? Yes. Is the stomach supposed to be on this side of your diaphragm or below it? Below it. And what's all this squished business?
That's the esophagus.
That's the esophagus.
All twisted up.
So what happened was this person had a hiatal hernia, which we'll talk about in a little bit. So the hiatal hernia basically is a piece of the stomach is coming back up through the entrance of where the esophagus goes past the diaphragm. So that was never repaired. She was just treated for it. She probably also now has gastroesophageal reflux because her LES is compromised. So everything kind of floated up there, and then her stomach twisted. So it twisted and made itself have now like two chambers.
So wait, I'm confused as to how they can treat it but not repair it.
You don't have to, and I'm going to talk about hiatal hernia in a little bit. So it depends on the degree of the herniation, but most of the time you can just treat it with acid reflux and they remain asymptomatic. In fact, most of the time they're just incidental findings. Usually this doesn't happen. So it just depends how big the defect was.
Can you go back to the previous slide?
Say again.
Can you go back to the previous slide?
Of course.
Thank you.
Sure.
Just as a survivor of a fire.
Who is? Oh.
Not like that.
And treatment is usually conservative, but you can go in there and surgically either just remove the area that herniated up, or put a mesh if the hole is big enough, or there's another procedure which I'm going to show you in a minute. Good. So, does anybody know what that's called when the stomach twists? Yes, gastric volvulus. So a gastric volvulus basically means your stomach has twisted. It can go either way. It happens a lot actually in dogs. I don't know if you've got anybody who has dogs, especially bigger dogs. Where they say if you feed them, don't exercise them right away because their stomach's not tethered well. It's not as common in people. But treatment of it, it just depends. If it was like that CT scan that I showed you guys, obviously you have to go in there and surgically repair it. So you'll remove any area of the herniation and then you'll pull the stomach back down and you can suture it in place so it doesn't move. So typically people that are prone to gastric volvulus have either some type of anatomical defect already or some type of ligamental kind of laxity that makes them more prone to their stomach, like twisting like that. Okay.
Professor,
Yes.
are we gonna get access to your PowerPoint?
Nope. You got what you got. I told you, you could take pictures, notes, whatever. Okay. So hiatal hernia. So herniation of part of the stomach back into the thoracic cavity. So the esophageal hiatus is the point at which the esophagus goes past the diaphragm and meets the stomach. So again, hiatal hernia frequency increases with age. Why is that? So what do we say also is that one of the muscles that weakens the quickest if you have malnutrition? Diaphragm. Also increased intra-abdominal pressure. So anything that causes intra-abdominal pressure, weakening of the diaphragm, or anything that is compromising that area of the esophagus. So ongoing reflux, acid exposure, anything that's just constantly weakening that area is going to predispose somebody to a hiatal hernia. So remember malnutrition, and this is in your hospitalized patients, obviously not in Justin's case. Um, and like I said, a lot of times these are just found incidentally. So probably a lot more people have them than we know, but you're not symptomatic and you're not going to get, you know, a barium swallow or CT scan or x-ray, so you just don't notice it. Okay, so there's different types. I put the two main types up here for you guys. Okay, so Chris, very smart. The angle of His that he was talking about before. So you see the little blue thing under A? That's the angle for the distal esophagus and the cardia of the stomach. So it should always have the angle that you see in A. Once that angle starts to get compromised, you see how in B the angle now is like much bigger? Once you start to lose that angle, that means that the anatomy is shifting for some reason, and you're increasing your risk of reflux and risk of a hiatal hernia. So then you see C, that's the more common type of hiatal hernia. So that's a sliding hiatal hernia, and you can see the stomach literally just slid up. And can you see the angle of His at all with C anymore? It's gone. With D, you see how the little piece of the stomach just snuck in next to the esophagus? On that one, your angle of His is maintained. So you can still draw that angle from the distal esophagus to the cardia of the stomach. So you're less likely to have reflux with the paraesophageal or next to the esophagus, or that one's referred to as a rolling hiatal hernia.
Say that C and D are the most common.
So yes, so C is more common. C is a sliding. D is the rolling. C is more likely to become symptomatic with reflux type symptoms because the angle of His is gone. But D is more likely to get strangulated. So you see that little piece of the stomach that's there is more likely to twist and have the blood flow become compromised. Do you remember which one you had, by the way?
I have the sliding.
Oh, okay. Very good. And then there's other, you know, there's other types that are kind of a combination of the two. But these are the two main. Yes?
I missed what you said about which one like causes of reduced circulation. Is it D?
So D, so you see that little like piece that's kind of bubbled up over there? That one has the higher risk for that piece to rotate and kind of get strangulated and compromise blood flow to that portion of it. And that's just a more anatomically correct view. Okay. Chris, what type of hernia do you think this is?
Sliding.
Excellent. So does everybody see that? You see where the diaphragm is? So that part of the stomach should not be up there past the diaphragm. So again, this is a barium swallow, or an upper GI is what it would be called in this case, because you're not assessing swallow, but it's same. You're giving contrast and you're taking the x-ray, and now the contrast really helps you visualize the anatomy really well. Okay, what is this called?
The angle of His.
Nice. So the angle of His. So the less defined that angle gets, the more likely that a hiatal hernia is going to occur. So B is kind of like a pre-stage to a hiatal hernia. And there's just anatomy of the stomach. And then here's the anatomy of the lower esophagus. So see where you guys see that whole entire lower section and portion of the diaphragm is part of the lower esophageal sphincter. And that remains shut when you're not swallowing. Okay, so hiatal hernia clinical presentation, typically with some kind of like pain in the chest, maybe difficulty swallowing, depending how bad it is. Associations with reflux is because of now compromised acid clearance from the distal esophagus. So a lot of times somebody with a hiatal hernia may just be diagnosed with reflux first, not knowing like what the underlying cause of the reflux is. You may also take a chest x-ray of this person. And if you might see something like this, so you shouldn't be seeing an air fluid level up by the heart. So that either means somebody's stomach is up there, or they have some gas-producing organism that's making a cavitary lesion in their lung. How can you tell from this view that it's behind the heart? It's hard, you really can't. So what could help you realize that it's behind the heart? Yes, a lateral view. Excellent. Or you can do an upper GI, so you could give them contrast and then take a picture. So that's like this one that I just showed you guys. Or you can go look with the endoscope. It's a little bit more difficult endoscopically to kind of orient yourself to where the heck you are, because clearly here you're seeing stomach, but it's not entirely clear when you're endoscopically in there. Are you past the diaphragm or not past the diaphragm? Are you in the stomach because you're past the diaphragm, or is the stomach migrated up past? That's hard to tell endoscopically, like orienting to where you are. So again, treatment, oftentimes very conservative, neutralize acid, maybe even prokinetic agent. What's two prokinetic agents that we know about? Metoclopramide and erythromycin, good, to help propulse the stomach. Surgical, if the medical conservative changes are not working, depending what the hernia looks like, that herniated sac might need to be removed. And then fundoplication, have you guys learned about that? So once the angle of His is compromised and that area of the diaphragm is compromised, it's really hard for the patient to not continue to have symptoms of reflux. So one thing that's been discovered is to just take a piece of the stomach and wrap it around the bottom of the esophagus and sew it to kind of make your own LES. But what do you think the problem with that is? Do you think that contracts and opens when it's supposed to? No. So you have a lot of issues with that procedure. So it's kind of a last resort thing to do. Okay, LOS. This surgical procedure can be performed to treat reflux and some hiatal hernias, but is not preferred. What is it called? You can phone a friend. Correct. So fundoplication, there's all different types. If it goes 360 degrees all the way around, it's named after a guy named Nissen. There's types that just go 180 degrees. So there's all different ones and variations. But again, this ends up with a lot of problems. Oftentimes it's pulled too tight and the person has ongoing issues still swallowing.
So does it make if the person can't eat as much?
No, it shouldn't be like so tight like a gastric band or something. But initially it takes a little bit to get used to. So probably initially they're not able to eat as much until they adjust a little bit. Okay. Cam.
Regulators. You regulate any stealing of this property, we're damn good too. But you can't be any geek off the street. Gotta be handy with the steel if you know what I mean. That's the key.
It was a clear white night, a clear white moon, and she was on the streets trying to conserve.
What do we have?
The condition is achalasia.
Correct, achalasia.
Song.
Song and singers, please. What? Correct, number 1. Correct. Warren G and Nate Dogg. What's the name of the song? Yes.
They took me more as well, they took my rings, they took my Rolex. I looked at the brother, said, damn, what's this? They got my homie hemmed up, and they all around. Ain't I don't see anything going straight down for five. They wanna come up real quick before they start the clown. I best
Nate
pull
Dogg
out
passed
my
away.
and bust this bad up. Just to my kid, I think I'm going down.
By the way, I almost had Warren G come for you guys' orientation. Yeah. But it fell through. It fell through.
No.
And I was gonna wear my shirt that says "Regulators Mount Up," but.
He can come anytime, sit in your classroom.
Okay, achalasia. So again, remember this is a dysregulation of neurotransmitters and neurofibers to the esophagus. So you have a lack of inhibitory neurotransmission to the LES. So if you can't inhibit the LES, what does it constantly do? It's contracted. And then you have a lack of excitatory neurotransmission to the rest of the esophagus. And so if that's the case, what can't the rest of the esophagus do? Peristalsis. It's very rare overall. I think it's like 1 in 100,000 people. But that's usually the age range of when it's diagnosed. It has a very insidious onset. What does that mean? What's insidious?
It just starts.
Very slow. So super slow. So by the time your patient with achalasia has symptoms to the time you figure it out, what do you think the average length of time is? 5 years. 5 years, because it's so slowly progressive. And also, you know, nobody does a history or a physical, so that's not helpful. So make sure you guys do a history and a physical. And then you'll figure it out before 5 years goes by. Almost 100% of these patients will have difficulty swallowing. It makes sense that they can't burp, right? If your LES is forever contracted, can you burp? No. So that's very telling. If your patient tells you, I can't burp, I feel like I need to and I can't. That's very concerning. Diagnosing it, again, upper GI. So you give contrast and take a radiograph, and it has what's called this like bird beak appearance. So like this bottom part supposedly looks like a bird's beak, like the bird's pointed upside down. I don't know who comes up with these things. Usually diagnosis is through imaging, but manometry and pH studies might also be supportive. So a pressure probe to check actually, you know, how much pressure is in the LES compared to what it's normally supposed to be, and pH monitoring because you're going to have potentially increased acid, because if you have a little bit of reflux from the stomach into the esophagus isn't able to clear it back down. Stan. This idiopathic motility disorder of the esophagus results in failure of the LES to relax, as well as loss of peristalsis in the distal esophagus. Correct. You didn't even need the hint. So do you guys see the bird?
What's the UGI?
Pardon? Upper GI. So upper GI study is when you give contrast and then you take a radiograph. And you can see anywhere in the upper GI. So how do you treat it? First, if you can try and relieve the symptoms by getting the LES to relax. So calcium channel blockers, nitric oxide, I mean, you can tell barely even really 10% benefit. Probably 70 to 80% success is the balloon dilation. The botulinum toxin is kind of hit or miss for getting the LES to relax. But you can actually just go right in with a balloon and inflate the balloon and kind of press the LES open. And it'll get it to stay open for a while, but over time it'll close again, so they'll need to have repeated procedures. They could potentially also go in there and do an incision in the muscle. But again, now you're totally compromising the LES, so then they may need a fundoplication so they don't have, constant reflux. Okay, esophageal spasm. I think we have a few more slides and we'll take a little break. So again, another one that's not very common. There's different categories, but I put the main ones for you guys in the lecture. Usually something triggers esophageal spasm, but it is thought that people who are prone to esophageal spasm have increased cholinergic stimulation or sensitivity to cholinergic stimulation of their esophagus. So again, these guys are going to present with chest pain and difficulty swallowing, because if you imagine, if your piece of your esophagus is spasmed, it's painful, and you can't swallow past it. Okay, Tolu. What millimeters mercury pressure is exerted, would you guess, during esophageal contraction during an esophageal spasm? So normal millimeters mercury of just like normal peristalsis and contraction is like 10 to 45 millimeters mercury. So in this case, it can be up to 180. So do you guys remember when you put your blood pressure cuffs on? And how high was the highest that you guys pumped it? And was that painful on your arm? And can you imagine that's your esophagus contracting even more than that pressure? So very, very painful. And oftentimes, what are you going to work up this patient for potentially when they come in? Yeah, exactly, an MI, so some kind of cardiovascular event, because that feels like chest pain. And that's why one of them is called nutcracker esophagus, because it's said that the pressure exerted from the contraction is enough to crack a nut. Yeah. 10 to 45. So when you image these guys, they call it, again, with whoever comes up with the words, but corkscrew esophagus or rosary bead esophagus. So you see how it's all spasmed? So it's not supposed to look like that. It's just supposed to be kind of one long, smooth tube.
Sorry, what was the range again?
Normal range is about 10 to 45 mmHg. So again, upper GI, if they're happening to have the contractions when you do the upper GI is helpful, but they might not. So that's difficult. The pressure probe, the same thing, because the pressure probe isn't something that they wear home. You have to do it in office, so they may not be having the spasm. So you need to actually do the study while they're experiencing the symptoms to catch it. Treatment's a little bit more tricky with these guys, but usually they do respond to medical therapy as far as helping the esophagus relax. When that fails, then surgery is the next option. So if it's a particular section of the esophagus that's spasming, you can actually go and just remove that entire section, which is not an easy procedure at all to remove a portion of your esophagus. Or potentially, again, like you see in that picture, if it's just a particular section, you can go through and make an incision in the muscular layer, and the mucosa, submucosa will kind of relax and pop out. And that's shown to have a little bit of success too. Balloon dilation, again, in this, if it's in a limited section, can also work. Okay, globus hystericus. So remember with this one, is this the first thing on your differential, and is the first thing that you diagnose your patient with when they come in and say they have a hard time swallowing? You're like, you can go home, you have globus hystericus. Okay, no, it's a diagnosis of exclusion. So you've ruled out everything. Also, all of those studies that we just went over, the upper GI, barium swallow, endoscopy, what are the results of those in order for you to diagnose this? Negative. So none of those, all those have to come back 100% normal. So it's thought to also be triggered by potentially acid, but more emotional types of stress. These guys have normal imaging and usually are not going to have, lack of appetite and weight loss and all those other issues that your other patients would have. So it has a very good prognosis. So building good rapport with your patient, figuring out what the triggers are, and potentially having psychiatry get involved too. I know you guys have seen this one before. If you're blank and you're tripping and you experience a persistent or intermittent non-painful sensation of a lump in your throat, what might you have? Correct. Name the song, M. Huh? What did she say? What was the name of the song?
Paranoid.
Yes. Thank you. Okay. I can't play very much of that one. Okay, esophageal webs. So remember I drew this little picture for you guys? So these esophageal webs can either be something you're born with or they're acquired. And can you see how there's just like a piece of the mucosa of the esophagus that just kind of went in? And so do you think food could get stuck there? Like if you're eating a giant piece of steak, do you think it's going to probably have a hard time getting past that? So this is going to be more of your patient that's complaining, oh, okay, it's like big pieces of food that are getting stuck. But probably liquids are not an issue with this. Treatment is to just rupture the web. So I'll show you a picture. You can go in with a balloon or sclerotherapy or electrocauterization and just kind of rupture that web. And it's pretty successful. Associated conditions, Plummer-Vinson syndrome. Have you guys heard of that yet? Yes. So it's a triad of symptoms: iron deficiency, inflammation of the tongue, which is called glossitis, and difficulty swallowing, dysphagia. It's not really understood why iron deficiency predisposes people to these webs. Clearly, iron is somehow involved in the, deterioration of the mucosa and submucosa of the esophagus. Any kind of skin condition that results in, big vesicles forming. Graft versus host disease. When I was in bone marrow transplant, I had a couple patients with this. So when you transplant a patient with another person's cells, those cells start to not recognize that patient as who the heck are you, and they'll start attacking different places of the body, and it can cause scarring and fibrosis of the esophagus, and sometimes cause development of these webs or rings. And then when you look through an endoscope, it looks like that. See, it's just kind of the mucosa and submucosa pouching into the esophagus. Yes?
Just to clarify, the web is the same thing as the ring.
So a true web only contains mucosa and submucosa. A ring also contains a muscularis layer, except for, remember Schottky got cocky when he wanted to name the ring after himself? Because that Schottky ring only contains mucosa and submucosa. So it really should be called, I don't know why I didn't just call it a Schottky web.
And Zinkers is the one that's going, right?
No, we didn't get to Zinkers yet. It's coming, Stan. Stay tuned. Schottky. Okay, TK. This condition presents as a triad of dysphagia, glossitis, and iron deficiency anemia. Correct. Plummer-Vinson syndrome. And then the last slide, and we'll take a break. So again, the rings, like I said, a true ring has a muscularis layer. The location deems them A or B rings. Again, I don't expect you guys to memorize that, but just understand the development of them and what they contain and what the symptoms are. Okay. I hope she's doing the halftime show this year. Would you guys like a break? Okay. You want 5 minutes? Okay. Zinkers is diverticulum. Yeah. And it's a false diverticulum because it only contains mucosa, submucosa, and it actually herniates through the muscularis layer. So, have you seen it one? No. Oh. Oh. Yes. Yes. So it's supposed to, but there's a Schottky ring for the ring, but it Yes, of course.
Okay, so I kind of wrote it all just because I wanted to practice. But should I write this something else in there?
Yeah.
That's fine.
Perfect.
And then for this, should I just put unremarkable? And then that was all, or just put unremarkable for all?
Well, did you actually ask them to use? Then you know, how do you know that?
So it's in nothing.
Correct. Yes,
And then
yes.
same, I didn't do this, so not obtained.
Correct.
And then labs not obtained.
Correct.
Okay.
Yep, yep. Very good.
Yeah, you want to see it? That's a good video. I submitted the application. They really would.
My shoes, I got them online. They're thanks. A-bound, A-D-O-U-N-D. They are. They're so comfy. I mean, yeah, exactly. When they're not soaked. Yeah.
Yeah, they would just like, they
Yes.
The graft, what is it? The
Graft versus host. Yes.
Versus host. When somebody does go through that,
Yeah.
what is the best? What's the next thing?
They are on a lot of immunosuppression.
Okay.
And so basically, it usually starts to happen when we try to start weaning them off of their immunosuppression.
Okay.
So it's kind of like this balance between keeping them so immunosuppressed that they're getting every infection on earth versus now you're getting rid of the immunosuppression and now those transplanted cells are starting to like recognize things you don't want them to recognize and they're attacking like the person's body.
Okay.
Yeah. And it all depends on how good of a match they were for each other,
Okay.
what the blood types were. So all that stuff, whether it's even male, you know, getting transplanted to a female or vice versa, all those things like determine how bad the graft versus host can be. Yeah.
Okay.
Yeah.
And I guess that's something the patient's aware of.
Yes. Yes. Yes.
Okay.
Yes.
Gosh, that's so sad.
Yeah. Yeah. It's crazy. It's really interesting.
It is. It is. I love immunology.
I know. You would love it then. You would love oncology if you love immunology.
Oh, really?
Yeah. Yeah, for sure.
I should look into that.
You should.
Is that why you went into it?
I really like immunology too, and the
Okay.
nutrition component of it too. I think that's so significant. So, yeah, and it's a lot of internal medicine. You don't lose anything. You know, you get get to see all the regular stuff plus all the crazy stuff no one else sees.
That's true.
Yeah.
Something to think about.
Yeah.
I remember when you interviewed me, we talked about it a little.
Oh, you did? Yeah.
But yeah, I was so sad.
I know. That part of it is, but
Yeah, it's interesting.
yeah.
Okay, would you like some?
No, I'm okay. You're so
Okay,
sweet.
okay.
Thank you. Those
Thank
are
you.
awesome. Though. I
They
love
are.
those.
Yeah, I think he has to like apply to she like he sent it to the school.
It's everybody back.
Instead of saying to reply, right?
Stanley, I didn't know where to put the H.
All right, guys, let's get back started. Almost done. Not that much left to go. Okay, Mallory-Weiss syndrome. So, upper GI bleed is oftentimes can be due to Mallory-Weiss syndrome. Mallory-Weiss syndrome is typically due to increased intra-abdominal pressure, so vomiting is usually the culprit. And it occurs because you end up with tiny lacerations or tears of the mucosa and submucosa of the esophagus. I'll show you a picture. So these patients will present with hematemesis, so vomiting blood. What's melena?
Stool.
And what is it called that? So it's like a tarry kind of color. What's hematochezia? So it's like bright red blood in the stool. Almost all of them present with vomiting blood. Endoscopy is needed to confirm your diagnosis. The good thing is probably 90% of these will spontaneously heal and not need any intervention, other than just supportive care. So hydration, blood replacement if that's necessary, acid reduction. If that doesn't work, just conservative management, then you can actually endoscopically go in and inject the area that's bleeding with the sclerosing agent or cauterize it. And if that still doesn't work, you can actually sew over the area, but that's pretty rare. Like I said, most of them spontaneously resolve. And as long as the person doesn't continue to vomit, then it's not going to be a problem moving forward. All right, Chrissy, what's your diagnosis? Excellent. Where is she? I heard her. Oh, there you are. So, and it's really this distal part of your esophagus that's most prone to tears and ruptures. There's more intra-abdominal pressure there, and the mucosa is more likely to be getting exposed to acid, so it's a little bit more vulnerable to tears or ruptures in this lower area too. So you see, are those all the way through the esophagus? No. Okay, so then you have Boerhaave syndrome, which unlike Mallory-Weiss is transmural. What does that mean? All the way through. So your esophagus is ruptured. So this has a very high mortality rate. So I think initially it's probably 30 to 40%. For it to truly be called Boerhaave's, technically, it has to be because of vomiting. But most of the cases is because, we went through and you're doing a procedure, an endoscopy, and you just, accidentally ruptured the esophagus. But that really shouldn't then technically be called Boerhaave's. So I think the person that it was named after overate and then threw up and ruptured their esophagus. So, say that again. So that's a really good question. Excellent question, Allie. So yeah, somebody who's bulimic or self-inducing vomiting is at risk for both of these. Absolutely. Absolutely. And the more the more that you're exposing your esophagus to acid, the more likely that that tissue can potentially tear or rupture. So yes, great question. So usually this patient's gonna, again, same with Mallory Weiss, they're gonna give you a history of violent vomiting, then all of a sudden kind of like a tearing pain. The pain with Boerhaav's is significantly worse than Mallory Weiss. In addition to that, what is this subcutaneous emphysema? What's that? Or mediastinal crunch? So there's somehow air got into their tissue or into their mediastinum. So where should air normally be in your thoracic? Inside of what? Either in your lungs or there's air in your stomach and intestines too, right? But it's sealed in there. But if all of a sudden there's a hole in your esophagus or there's a hole in the pleura of your lungs, then that air is going to escape out. So subcutaneous emphysema, has anybody ever examined somebody with it? It actually, if you put a bunch of Rice Krispies, or like when you get the packaging things that you pop, the little, okay. That's what it feels like when you're pushing on their skin. The air trapped under the skin, when you push on it, has like that little Rice Krispie or package popping kind of feel and sound to it. That's very bad. So on just a plain radiograph, what you'll see is that the mediastinum looks really wide. And you may even be able to see the subcutaneous air. If you're going to do an upper GI or give them contrast and then take a picture, you want to make sure that you're using a contrast agent that's water soluble and non-irritating. So if you ever suspect that your patient has a hole in their GI system, whether it's their esophagus, their stomach, their jejunum, colon, whatever, you don't want to give them barium, because it can leak out and into their tissue or into their abdominal space or wherever, and it's very, very irritating. And it's going to cause a massive inflammatory reaction. So gastrographin is water-soluble contrast, and it's much less likely to cause irritation to body tissues if it's not contained inside the organ. So why not just use it all the time? It doesn't image as well as barium. Correct. Yes. So treatment for Boerhaav's is really aggressive. So unlike Mallory Weiss, where most of them just heal on their own and you just need to give a little support, I mean, your patient's going to die if you don't surgically intervene. So they, probably usually will need to be intubated. They'll have prophylactic antibiotics started because they have all kinds of gut organisms now getting exposed to the rest of the body. And they'll have to have that section that ruptured likely resected. Okay. Key, to solve the case. A 55-year-old male with a history of alcoholism presents to the ER with a history of violent vomiting. He appears acutely ill and complains of experiencing excruciating lower left chest pain. Your physical exam reveals epigastric tenderness, his abdomen's rigid, and you feel crepitus along the base of his neck. What's crepitus? So crepitus, kind of like not as much as the Rice Krispie thing, but almost, when you guys like move your knee or a joint and you kind of hear that like squeaky kind of clicking a little bit, that's crepitus. Okay, your chest radiograph looks like this. So can you guys tell on this radiograph that there's widening of the mediastinum? Something there looks like it's more this way than it should be. And then you see where those little arrows are pointing to those little air spaces. It's not super obvious, it's hard to see, but that's air that's like trapped in the tissue. that shouldn't be there. What's your diagnosis? Yes. Boerhaav's. Very good. Okay, Wend. I'm going to give you a series of questions. Tell me if it's Boerhaav's or Mallory-Weiss. May result from vomiting. Both is correct. Transmural perforation of the esophagus. Boerhaav's is correct. Longitudinal mucosal tears of the esophagus. Mallory-Weiss. Alcohol use is a predisposing factor. Both. Both. Interestingly, Boerhaav's most commonly affects, like 80% of people with Boerhaav's are middle-aged men. I'm assuming because of just increased likelihood of drinking, binge drinking, and vomiting. Okay, esophageal varices. Again, I'm going to go much more in depth into this when we talk about liver disease later in the semester, but since we're on the esophagus, I had to mention it. So, an esophageal varice is a vessel of the esophagus that is now bleeding. So, what causes that to happen? Portal hypertension. Okay, what does the portal vein carry blood to the liver or away from it? Because what is it doing to the liver? It's feeding it and taking all the crap there that the liver needs to deal with and detox and fix, right? Okay, so if the portal vein is carrying blood to the liver and the liver is fibrosed and cirrhotic and jammed up with just dead tissue and excess collagen, do you think that now the blood that's trying to flow in is going to start building up pressure? Yes. So anything that drains to the portal vein now is going to have backflow of pressure. So let's see. Does your esophageal vein drain to your portal vein? Do you guys remember? Your esophageal vein drains to what other vein? Anyone remember? I'll draw a picture for a clue. Yes. Azygos. Okay. And then the azygos drains to the SVC. So the esophageal veins have no problem. Okay, they're not getting affected by portal hypertension or portal pressure. It's the tiny itty bitty superficial submucosal vessels that ultimately drain into the left gastric, that ultimately then drain into the portal vein. So then the portal vein's trying to go into the liver, but the liver's just jammed up with fibrous, crummy collagen from cirrhosis. So you have backflow of pressure. So these tiny little superficial vessels that are normally a millimeter or less in diameter become huge, like a centimeter or more. And they're not meant to be that big, so their walls are really prone to rupturing. So typically somebody with varices, you can assume, has some underlying issue with their liver or something else that's causing portal hypertension. Yes?
Is another name for that thing with Medusa?
Oh, excellent. In a different location. So caput medusa is engorgement of collateral vessels that are formed, because your body, when you have portal hypertension, it's like, okay, well, you know what? Forget it. I want to figure out how to get all this blood flow eventually to where? The IVC, right? So anything that's supposed to go to the portal vein and it can't because there's all this pressure, collateral vessels will just try to, like, they'll make themselves shunt over to the IVC, but they're not meant to do that. So they end up engorged, and you can see, like, it looks like basically snakes, medusa. And we'll talk about that when we go into liver failure later in the semester. But good, Bradley, really good. So again, most commonly the varices will bleed in the distal esophagus, but the blood loss is like massive. So they're very vascular. High morbidity and mortality, not just from the bleeding, but what's the underlying issue here? For why? Right, you have liver disease. Is liver disease, like, once it gets to the point of cirrhosis, something you can just fix overnight? No, so that's why the mortality is so high, because the underlying cause of it is going to be you can't really reverse cirrhosis, so you have to figure out what are some other things you can do to stop their variceal bleeding. So risk factors, alcohol, viral causes of hepatitis that ultimately can become cirrhosis. Do you guys remember schistosomiasis from diagnostic skills? What's it also known as? Snail fever. Good. Why is that on here? Because where does this parasite like to migrate to? And the liver. So risk factors for whether or not the varices will bleed, I have up there for you. So size is a big risk factor. How big that vessel is will determine whether or not it's going to rupture and bleed. There's different classification systems. Again, we'll talk about this when we talk about liver disease, but the child Pugh classification depends on, does your patient have ascites, what's their bilirubin, what's their albumin, and it gives you like how severe basically is their liver disease. So they have all these different fun names for when you go in and you look at the esophagus that are called red color signs. So the red whale markings, okay, you guys ever, cords, when you wear cords, like corduroy pants, you know how like there's those lines? So apparently they're called whales, which I didn't know, but so when you see these red streaks on the esophagus, that's an increased risk that the varices will bleed. If you see cherry red spots, so if you see this bright flat red dot over the varices, it has an increased risk of bleeding. And then the hemocystic spot basically looks like a little blood blister. Those also have increased risk of bleed. So by the way, when you guys build your differential can either be symptom-based or underlying disease-based. So you see, why for esophageal varices, why do I have duodenal ulcer and Mallory-Weiss tear as on my differential? Because why? What is it? Right. So when if your patient has varices, what do they present with? Hematemesis. If your patient has Mallory-Weiss, what do they present with? If they have peptic ulcer disease, what might they present with? And then same with maybe they're passing, blood in their stool too. So that's why those are on your differential, because they have the similar symptoms. Versus now you've diagnosed varices, and now your differential list is what is the underlying disease causing the varices. So schistosomiasis is because it causes liver disease. So where it says signs of liver disease, like Bradley said, you're looking for other signs of liver disease in your patient with varices. And likely, you know these things about your patient because this is a chronic patient. But the caput medusa, or the really prominent vessels on the outside of the abdomen, different other skin findings. We'll talk about some of that in lab this week in physical diagnosis. What about what's a skin or sclera change of a patient with liver disease? Jaundice. So you're looking for all those kind of things too. Endoscopically, you can go in and, again, either cauterize the vessel, potentially sew it. So there's a lot of really good endoscopic techniques for stopping the bleed. But these patients definitely need to be supported with either blood or water. They need an NG tube to suck all that blood out, because remember, the blood is irritating. It's going to make them keep vomiting. They can aspirate, and it can cause diarrhea as well. Because they have underlying liver disease, they're placed on antibiotic prophylaxis to protect them from gut gram-negative microbes. And if you're not able to endoscopically go in there and stop the bleed, which is really bad, there's this tube, and I'll show you a picture of it, the Sengistaken Blakemore tube, where it's an NG tube that you put down, and while it's sucking out the blood, you can actually blow up a little balloon at the bottom, and it kind of tamponades or puts pressure against the lower wall of the esophagus and stops the bleed that way. So again, I'll go into this much more in depth when we talk about liver disease, but that's what that looks like. See how NG tube goes down and you're able to suck out the gastric contents, and you see that red area is the balloon. So you can inflate that and it'll press against the vessel. So it's basically putting pressure on the vessels that are bleeding to try to get them to stop bleeding long enough so that you can go in endoscopically and possibly cauterize them or tie them off. Because if there's a massive bleed and you're going in there with the endoscope, you can't see anything. It's just blood everywhere. So, okay. Esophagitis. Again, can lead to esophageal dysphagia. Most common cause of infection in the esophagus is either due to herpes, CMV, or Candida. You're more likely to see these kinds of infections in the esophagus in a patient who's immunocompromised. But what do you think, like somebody who's taking asthma medications, or even maybe allergy medications, what medication could you think of that would predispose a patient to Candida esophagitis or oral thrush?
Steroids.
So what kind of systemic steroids for sure, but what other kind of steroids that's directly affecting this region? Intranasal or inhaled steroids. So steroids significantly increase your patient's risk of any kind of invasive fungal infection because they affect T cells. Does everybody know what thrush is? So it's like it's basically Candida infection. And usually when it's in your mouth, it's referred to as thrush, exactly. Reflux can cause inflammation of the esophagus, obviously, acid irritation. We talked about pill getting stuck. And then NG tube placement can cause irritation and inflammation, and then radiation therapy to any of this region can cause inflammation too. So that's, well, let's see. Ash, what do you think this is? It is. What do you know from what? Yes, Candida esophagitis. So Candida infection has a very specific look about it. So you see how it looks like those kind of white, raised, irregular plaques. It's very irritating, very painful. So you would see that same almost appearance in somebody's mouth. So if somebody comes and they have this, there's got to be some reason for it. Likely, like again, if they're immunocompromised, then that might be the reason. If they're taking systemic steroids or inhaled steroids, that could be the reason. Or even, a long course of antibiotics that throws your flora off could potentially be the reason. What common systemic illness puts somebody at risk for this? HIV, even like more common than that. Like two of the biggest leading causes of problems in health. Diabetes. Who said diabetes? Yes, diabetes. So persistently high blood glucose. The Candida loves that. Okay. So again, they'll present with pain and difficulty swallowing. For these infectious causes, you need to go in with endoscopically and take a biopsy and culture, or even gram stain. You can even gram stain the yeast so you can see them. And then treatment is with some type of, depends what it is, right? If it's fungal, it's antifungal. If it's viral, then it's an antiviral. So it depends what the cause is, and you'll treat it, it'll go away. And that's why important too, when you guys, have you guys learned about asthma yet? So when you learn about treatments for asthma, or anybody who's taking inhaled corticosteroids, for them to do it properly and then have correct oral hygiene afterwards, so you don't have the steroid just staying in contact with the oral mucosa and the esophagus. Okay, here you go, Stan, it's Zenker time. So Zenker diverticulum is because have you ever heard of like diverticulitis? Yeah. Where is that usually? So in your colon, but this one is actually in your esophagus. The etiology is not known. Again, it's an insidious onset, so it happens slowly over time. It's very rare. Your patient presents with difficulty swallowing, regurgitation, especially at night, they're choking and coughing. Steph, what's your diagnosis? Correct. So can you guys see? So this, again, we gave this patient some contrast and took a picture. And do you see where their esophagus just pouched out?
That's usually like in the posterior.
That's correct. That's correct. Very good. And then this is kind of a little bit of a better picture. And truly, it's a false diverticulum, because this part of the esophagus that herniated out actually herniated through the muscularis layer. So for it to be a true diverticulum, if you want to really get technical, it takes all layers with it. If it goes through the muscularis layer, it's, false diverticulum.
Can it continue like expanding?
It can. It can. And if it's asymptomatic and it's not causing any issues, it'll be fine. But what happens is, you see how then food and liquid starts getting stuck there, and because of its location, it's increased risk of aspiration, halitosis. So the person usually ends up becoming uncomfortable and having symptoms from it. What's bronchiectasis? Good guess. No.
An infection of the bronchioles that gives you a lot of air spaces.
Close. So irreversible dilation of the bronchial tree. So it's stuck open. So air is trapped. So anything that causes hyperreactivity of the bronchial airways. Okay, what's the opposite of that? What do you call it when your little alveoli are collapsed shut? Atelectasis. Good. So diagnosis, barium swallow shows really nicely, as you saw with that previous picture. And then treatment is very good. So they just surgically go and remove that little area of the diverticulum and sew it closed. And that's it. Quizlet. So the winners of Quizlet today get backpacks.
What?
Yeah. I have the coins to redeem for the backpacks right here.
Whoever picks me, I'll just.
Come on, you never know. You're going to win today. I feel it, Chris.
I'm terrible.
I feel it.
Hey, Tia, you suck too, alright?
Steph, come get new ones. I used up all the ink. I'm just gonna give you a packet to have. Okay. Okay.
What he said, he said, okay, and you do questions. I was like, okay.
I like it, Mo money. Oh, is that? All right, everybody's ready?
Kangaroos, where am I? Kangaroos! I didn't know it's not a two-way tree.
I'm always in a three-person team. Always.
Okay, let's go back to
So you pick.
Everybody's ready? Yes? Are you ready, Chris?
I am ready.
Okay.
Let's try to change.
Okay, here we go.
So nervous.
Oh, I just realized, I think I forgot to like post last week.
No, it wasn't. You know what
But I
happened?
need a
I stayed calm.
photo of the chaos.
That's what happened.
Boomerang the kangaroos. Hold on.
Oh no.
Okay, I'm gonna count to 3.
Dunk on David Tuesday, that's right.
It's only when you're gonna get money.
Oh, wow, that looks much.
All right, ready?
Are we showing something?
You're doing a kangaroo. Oh wait, no, you have to do the kangaroo. Yes. Okay, I'm gonna count to 3. 1, 2, 3.
I'm the crazy kangaroo.
Oh, did anybody see the thrush? The bird? The bird is a thrush. Like that's the kind of bird.